speaker, and the next speaker will be Cara Kosack from Médecins, Frontières, and her talk will be on testing for other infectious diseases at point of care, successes and challenges in implementing HIV diagnostics. Thank you, Cara.
Thank you very much, Daniela. Thank you very much for inviting me to the Union Conference. TB is usually not personally one of my focuses, so this is probably why I've been invited to talk about HIV diagnostics and what we can learn from the experiences we had in the past. In MSF, the point of care diagnostics in the area of HIV we use is a rapid diagnostic test, classical lateral immunoflow assays for the diagnosis. And lately, well, since 2009, we have also been using the PIMA from malaria for point of care diagnostic for CD4 counts. We are planning to do other trials on upcoming diagnostics in the area of HIV for CD4, the Xiomics, the Dactari and Burnett are some of the diagnostic tools that are in the pipeline. For viral load, we plan to work also further with Cepheid. The Samba is a platform that is interesting to us, and for early infant diagnostics, there are also parts that are developed as platforms by the Northwestern University and also by the group from Heavenly. I'm going to talk in the first part of this presentation about HIV rapid diagnostic tests and where we have used them, and in the second part I will focus more on CD4 technologies. So a little bit an overview about the number of rapid diagnostic tests we have been using in MSF in the last 2.5 years, and usually we have a yearly use of 1 to 1.2, 1.3 million per year. However, these numbers do not include local purchase. So these are the ones that leave our procurement and supply centers from Europe into our programs, which should be the majority of the tests. So as you can see, our main test that we use is the determined test for malaria. And we also, and number 2 is usually the Unigold, followed by some others. But the big part is one test that makes the most of the procurement. And I'm focusing on this because what we see here is a high number of manufacturers and devices we have available we can choose from, so which creates a market that has the potential to be more evenly distributed than we see at the moment in some of the TB diagnostics. Where do we use HIV rapid diagnostic tests? We use them primarily in our programs for screening of potential blood donors, classical VCT programs, voluntary counseling and testing programs, provider initiative counseling and testing, in antenatal care settings, in prevention from mother to child transmissions programs, in home-based counseling and testing settings, and in community-based testing. However, what we have been doing in the last years, we have overall been moving away from the testing as such, because a lot of other actors have been becoming involved in testing, and that is a task that we then saw could be overtaken by other actors. So we overall reduced our activities as such. So I would say the main focus is actually the screening of the blood donors and antenatal care provision at the moment. We are currently doing a multi-site evaluation of HIV rapid test, where we needed classical voluntary counseling and testing centers, and it wasn't easy to find within our programs sufficient throughput of these services, because we really moved away from those a bit. I think most of you are familiar with some of those devices. I've displayed here the determined test and the Unigold, where you can see that really a drop or small quantity of about 50 microliters is displayed on the membrane, and then with the buffer or without migrating through the lateral flow device. And I'm saying this because later on I want to tell you a little bit how people can be creative in misusing the test. It sounds simple, but in fact, when we see it used in the field, a lot of errors can be made when using these tests. So, what have we learned from using HIV rapid diagnostic tests? First of all, I want to talk about barriers on uptaking these tests, and I think similar issues can be observed in the TB world. So first of all, we see a lack of knowledge on HIV, what it is, how it can be transmitted. We see a false perception of how the risk for a patient is to be infected. So they think they are not feeling sick, so they cannot have the disease, so there's no need for testing. There's a big fear of stigma. So when I go to, and have recently implemented some of our study sites in sub-Saharan Africa, the VCTs are really not very confidential. So very often there is the HIV clinic within a hospital where people have to go to get tested or for follow-up. So as soon as you enter this part of the hospital, it is very clear you come for an HIV service, whichever that means. So as soon as you are seen in this area, it is clear you have to do something with you has to do with HIV, whatever this is. So you put yourself at risk, etc. So the stigma is already, because we do not have it integrated in our normal clinic flow, it is already right there because the services are provided in a separate area of the hospital. What we also see is a really bad impact on positive results. That is in the family, within the workplace. There's still a lot of issues and fear related with coming out with the positive status. Very often counseling and testing services are not really accessible for a lot of the population, especially in rural areas. And logistics is always a big factor. Poor planning of counseling and testing, stock ruptures, staff availability, storage conditions are just some of the things we are facing. Problems. What we see a lot when we talk about provider-initiated counseling and testing, we see a patient being treating, for example, for a chest infection in a clinic, getting IV antibiotics, and then the doctor prescribes an HIV test. So this is written in the chart, and then we send the patient to the counseling and testing, or the counselor comes and tests, but often the assumption is made that the patient has been informed about a potentially being infected with HIV, and the patient is not really being informed about why this test is being done, why it is a possibility that he or she may be infected. And then what we see very often, the patient is bombarded with a number of information and blocks, and there's a lot of fear of being open to testing, and then the patient refuses. So this is only the barriers we do have for getting tested. So when we talk about the testing procedure itself and the errors we observe over there, it is that we see that kits are not properly stored. In areas where we work, we have temperatures up to 45 degrees in some of our storage houses. This is not ideal for lateral immunoflow assays, and we do not know how these high temperatures affect these tests. A lot of the kits are used after expiration dates. I have seen clients were not identified, so we have a lot of clerical errors. We have seen that the blood after a finger prick is deposited immediately on the membrane of the lateral immunoflow, so not the right amount is supplied. We see that wrong tools when moving blood are used, so double or triple the quantity are put on the device. We have seen that when buffer is running out, the buffer is substituted with water, saline or water for injections, which can lead to false positive results. Our colleagues from the Institute of Tropical Medicine in Antwerp, they tested these extensively on malaria rapid diagnostic tests and saw a lot of false positive reactions when substituting buffers or water for the buffer that comes with the testing devices. I've also seen, actually, because it's in Paris, we have once been here for a demonstration of a cholera rapid test, and to demonstrate the lateral flow, the person from the company just used a drop of tea from his tea he was drinking, and actually we had a positive result with this, right? So you have to be really careful in what substitute you use to use these devices, right? I mean, we were healthy, we didn't have cholera, but he was a bit surprised himself. So these should be checked as well. Not a lot of people know this, but it's something to make users really aware of. I think a very big error I see very often that the incubation time of these assays is not respected. So as soon as the lateral flow of the fluid has been done, the control line is visible, the result to the patient gets read. However, the incubation time of 15-20 minutes of these devices is not respected. Thus, it is thrown in the bin, and all positive test lines developing after the control lines appears do get unnoticed. So the client receives a negative result, and this is particularly common when we do serial testing. That means the first test is negative, not a second test is done. Patient receives a negative result, a false negative result, leaves the clinic, although if the counselor had waited the full incubation time, there would have been a positive result on the first test, and subsequent testing should have been followed. The other thing is what we unfortunately see very often. Once a counselor has received the testing training, there is no follow-up on supervision on how the testing is being carried out on a regular basis. So basically you receive a certificate for all and good, and you carry on your whole life, and feedback is rarely given to the staff carrying out these tests. HIV testing in resource-limited setting doesn't rely on a single test. So, and various testing algorithms are in place, and unfortunately a lot of governments are still relying on a serial algorithm with a tiebreaker to give an a definite diagnosis for HIV. And we have seen that this is less than ideal. The WHO has never been recommending this, but however, and also the recent guidelines on this algorithm has been revised. So we really hope and push for changing these algorithms, and also testing these algorithms within country and also within regions, because we know that one algorithm for an entire country may not serve the particular needs you will see in this setting. What we also see a lot is that the algorithm as such is not really respected. So very often we see, okay, we run out of the first test, let's just use the second test. Oh, I have seen another test on the market. If we need 2 tests to diagnose, let's just substitute to see what is with the test that we have locally available. And that really shifts the accuracy of the diagnosis we give out. In some of the cases, especially when we see indeterminate results, we send serum samples or plasma samples to a reference lab or a regional lab for further testing, but a lot of the results or the samples get lost on the way, so there's no proper follow-up, and we lose the patient on its way. I'd like to have a few words on quality control and supervision. I mentioned earlier that there's no organized supervision of operators in place, so no systematic approach to supervise on a local or national level. Sometimes staff refuses to be supervised, so counselors often refuse to be supervised by laboratory staff. We have seen this. We have seen the mistake that a positive serostatus is announced with only one positive test. 1 minute, oh my god. And we also have no regular internal quality control of our test, and also lack quality control material, and we have no enrollment of our HIV testing in external quality control at this very moment. Okay, I speed up. I speak very fast now. The last thing I would like to say on the HIV testing is really that there's a big problem with linkage. So a positive status, a test, carrying out a test, doesn't mean that the patient is going to be linked to care. The linkage is a disaster. I have to say it drastic like this because it is. So I just want to say that recent data from our project in South Africa, and other actors are not better on that. We had a meeting last year in London where we only talked about linkage for an entire day on how to improve it. We only link on average 42% of the positive clients. They come to follow up. That's bad. And we are not the only ones facing that. So when we have a diagnosis, we gotta work on a system where we get our clients better into care. Yeah. So we have looked a little bit on the different kinds of testing, whether they can improve the linkage or not. You can see the numbers for yourself. I just want to have a little word on the PIMER. So these are some of our publications that we have used where we saw that one or other algorithm doesn't work very well. You can have a look at this if you want. I just want to have one word about the PIMA if I want, because I think there are similarities to the TB diagnostic, because it's a little bit more complex than classical lateral flow immunoassay. So these are a little bit about the numbers we have been using in MSF. So it is not as point of care as we would wish. We can't use it without a good structure and somebody with a bit of knowledge of testing. The price with $6 US per cartridge is still relatively high. But I want to say a little bit about the problems we have been facing with the PIMA. And the biggest problem we do have is the number of rejected cartridges. And in a multi-site analysis, we see on average 13%. And the other problem we have with the PIMA as a device as such, and that is nothing against Alera, it's just like how the product is designed at this very moment and the complexity of it, that we really can't use it in areas that are really warm. So in clinics in sub-Saharan Africa, our PIMAs refuse working. Yeah, so similar things we know with a gene expert. You need a lab, you have to invest in the infrastructure, air condition, etc. So we analyzed in a detailed way with the experience of 9 countries the error rates, why we do have such a high error rate. And overall, we have to say that 92.5% of our instruments had an invalid rate of more than 5%, which is actually the target from Alera as such. So overall, these are implications we face that increase the cost, but also the turnaround time. And then a point of care test doesn't really become a point of care test anymore, because we have to redo the patient. We have other patients waiting in line. We have to resample. And really the confidence also of the staff and the client goes down with it, especially if we see 2 rejections in a row, and that leads to a lot of frustration. Can I have one more slide? Yeah, negotiate. Wow. Okay, so anyways, target product profiles are not the task of this workshop, I think, or this meeting. So this will take place at another meeting, and I don't want to really emphasize on this. in specifics, but what we really would like to see, that we see no monopoly and that we want to see quality assured production of devices that we're going to use in the future. Thank you very much.